The second panel is about Medicaid and health coverage for poor people, poor kids. I think something that is also not adequately discussed. There was a little piece in the New York Times that described, and unlike, I think I share the skepticism of the former questioner about the New York Times, but it seemed pretty accurate, that related a study about how being on Medicaid actually has the same sort of returns on investment that pre-K does, a very similar kind of study just released. I thought it was pretty valuable. I don't know if that will come up here, but I'm going to pass it over to Amy to moderate. Amy, we really appreciate your being here. Amy Goldstein, staff writer at the Washington Post for 25 years. She writes about social policy issues across the nation, was part of a team awarded the 2002 Pulitzer for national reporting for the coverage of 9/11 and the government's response. She's now focusing her reporting on the 2010 federal reshaping of the U.S. healthcare system, which I think is underway, right?
So it seems.
So Amy, I'm going to throw it to you. Thank you all again. I want to stress in particular, we may spearhead a movement to try and get America to adopt some kind of a version of a millennial development goal to cut child poverty in half. So stay tuned. Amy, thank you. Thank you all, panelists. Appreciate it.
Bye.
Thank you very much, Jeff, and good to be with all of you. And I have to say, it's interesting to be a journalist in an advocacy session, because my role here is to sort of elucidate the conversation and not to take a position on what you're all going to say. But I'm very interested in what you're all going to say. And just to set the stage, as Jeff noted, this panel is going to taper our morning's conversation from how to help fewer children to be growing up in poverty to what's going on with the health and the health care of children who are poor or in families that are nearly poor. And I say health and health care separately because those are really two parts of what I think of as a trilogy, among which, if you listen closely, you'll hear these three panelists roaming this morning. So health insurance in this context really refers to Medicaid, which has been around, as you all know, since the mid-1960s, at least in most states, not all states go back that far, and the Children's Health Insurance Program, which is called CHIP or S-CHIP, depending on who's in the White House, which goes back to the late 1990s and was intended for the children of working poor families. So we're going to be talking a little bit about what these programs are achieving, whether there are deficits, and whether there's anything that can be done about those deficits. Health care is very different. Health insurance may be a prerequisite to health care, but it's not the same thing. And the questions for this panel are whether poor and nearly poor children have differential access to health care than other kids, and if so, why, and what maybe can be done about it. And then there's health, which is really the bottom line. So some of the conversation this morning is going to be about how health is influenced by the other two, health insurance and health care, and by other factors in the lives of poor children. And if you listen, you'll hear, I think, some cross-cutting themes, one of which is to the extent that poor children are disadvantaged in their health, how much of that is a function of the healthcare system and how much, as I was just saying, is really a function of social determinants of health. And I think you'll hear these folks talking about that continuum of causes. And then there's the question, which is running through all of this, of what difference the government makes, what government programs are doing, how well they're working, and how they might be strengthened. So I'm going to introduce each person before he or she speaks, and we're going to start with Matthew Davis, who's at the University of Michigan, where he's a professor of pediatrics and communicable diseases, professor of internal medicine, professor of health policy and management, and those are just some of the professoriate positions that he holds. Since 2013, Matt's also had a foot planted firmly outside academia as the chief medical executive for the state of Michigan, which means that he thinks about such issues as Michigan's expansion of Medicaid under the Affordable Care Act, ways to curb infant mortality, and the state's readiness regarding Ebola. And when we spoke in advance the other day, he said this perhaps heretical statement: Medicare is a valiant but ultimately handicapped effort. So he's going to talk a little bit this morning about the status of health coverage for kids, some of his research regarding medical homes, and the link between mental health and primary care. Matt.
Thanks, Amy. Good morning, everyone. Thank you to the Century Foundation for hosting us this morning, and I hope you all enjoyed and appreciated the first panel as much as I did. I'm looking forward to our conversation here this morning. Before I go any farther, it's important for me to state unequivocally that because I wear a couple of different hats, as Amy was describing, I am here in my capacity as a faculty member from the University of Michigan this morning. I am a state health officer within the state of Michigan, but none of the remarks I provide or the opinions that I express should be construed as the official position of the state of Michigan, the governor of Michigan, or the Michigan Department of Community Health. I'm sure you all sitting here in the city can understand why I just said that. But it is a delight to be part of this discussion this morning, and I wanted to pick up right where Amy introduced us in terms of focusing on this question of access and the connection of access and insurance. And I'm proud to be a practicing pediatrician, as are my fellow panelists here, who think on a very frequent basis about what is going to help our patients do best. Certainly insurance is one of those things because it does provide access, but quickly we realize that access is not the full story, and that what we really need to focus on is something that describes better the services that a medical system, a healthcare system can provide. The description for that wholeness is called the medical home. And in pediatrics, folks started thinking about providing a medical home for children and their families about 40 years ago, soon after the enactment of Medicaid. The rest of medical care has really picked up on this theme and has really taken on the idea of medical home as something that is universally important and valuable. The question is, when we look at our healthcare system today, and even we look at the first group, children, for whom medical homes were an emphasis, how well are we doing? Amy mentioned that my colleagues and I have done some work on this, and we've used some national data to look at just how many kids out there do have a medical home. Just like a home or a house, there are several different aspects of medical homeness. What would go into that measure, for example? One of them is having a usual source of care, a usual provider. In fact, someone, hopefully, who you can name and say, yes, that person is my doctor or nurse practitioner or member of my care team. Also, do you have family-centered care in that environment? And does your child receive care coordination when he or she needs coordination from that primary care setting to other settings? Those are some of the key elements of whether a child has a medical home. And there's a rigorous and reproducible way to ask about that. And when we ask over 100,000 families on a regular basis at the national level through something called the National Survey on Children's Health, which you could go and look up today online. They have a very user-friendly website. The National Survey on Children's Health informs us that only about 55 to 60% of children have a medical home today. 55 to 60% may sound low to you. It certainly sounds low to me as a pediatrician. For some people who are looking at the medical homeness for adults, it's actually a very high number, right? But be that as it may, we hope, we want to understand if there are disparities in the availability of medical homes for kids. And unfortunately, the answer is yes. One of the critical discriminating points about who has a medical home and who doesn't is what sort of health insurance you have, or whether you have health insurance at all. So it turns out children with private health coverage, in about 2/3 of cases, 67%, have a medical home, whereas children with public insurance have a medical home 20% less frequently, high 40%. And if you're uninsured as a child, you have a medical home about 30% less often, just the high 30% range. So clearly we have a challenge here that is not just about access, but about really receiving the full body of care that we would hope to provide each child. We could go on, and many conferences do actually, go on about, well, so what should we do about this? For my remarks today, I'd like to focus on one particular area that I continue to see, both as a clinician and as a researcher, is an area where medical homes tend not to do so well. And that is in the coordination of care for mental health, or in what's referred to in the child literature and child policy circles often as behavioral health. Behavioral health is a more general term that captures not just serious mental illness, which a very small proportion of children experience, but behavioral concerns that parents have about their children interacting with peers, interacting with family members, and interacting within one of the most important environments that they have, which is education. Colleagues of ours at Yale took a look at similar national data about kids with one or more of these behavioral health conditions and found that in 40% of the cases, these individuals, these children, did not have a medical home, and the thing that was missing the most often was care coordination. Well, you might be thinking, of course, because you all have probably heard the national conversation that in fact we don't have enough behavioral health specialists to really address all the needs that children in our communities have, and that is correct. So if you don't have enough behavioral health specialists, how can you possibly coordinate their care? There are two emerging answers to that question. They're exciting answers to that question, and they are answers to that question that depend fundamentally on how we can roll out new policy ideas, and I'll explain why in a second. One of these responses to the challenge of behavioral health care coordination is co-location. Co-location is the idea of putting a psychiatrist or psychologist right there in the primary care setting. I've had a chance to experience this in a clinic at the University of Michigan, and it is transformative in terms of what you're able to do for a family, for a child, at the point of care. You can see that child for physical health concerns, for example, and then say, and now you have an appointment with Dr. So-and-so, and walk right down the hall, and they have the appointment at that same visit to the clinic. Maximal convenience for the family, maximal impact for the child. Yet, if we don't have enough behavioral health professionals across the country in general, we're not going to have enough to support a co-location strategy across the country. We're going to have to do something much more about the workforce of mental health professionals in order to try to support that strategy. And I'll get to that at the conclusion of my remarks in a couple of moments. But I wanted to share with you another approach to behavioral health coordination. And that is an approach that's called collaborative care. And here the idea is, bless you, that you don't necessarily have psychiatrists and psychologists right in that primary care setting, but instead you have a social worker or even a community health worker who has particular training around behavioral health. And that person is also there, but they're in a capacity that has a broader array of services that they can offer to those families. So not just a mental health professional who's trained very deep, but rather a person who has broader training, which includes behavioral health, comfort, and skill sets. Those individuals help the primary care doctors appropriately diagnose and then institute an original form of treatment. And then if that treatment doesn't work out for that child and family, then those individuals also help with getting those children into a higher level of care for their behavioral health needs. Co-location has fantastic outcomes. It's been studied principally for adults, but in the few cases where it's been studied for kids, there are remarkable improvements in terms of the children's symptoms, the family level of distress, etc. It turns out that this approach of collaborative care, using people with a little less training but specializing in behavioral health, has excellent outcomes as well. So it represents a great opportunity to invest in this sort of change in the practice model in a way that is more sustainable and is more feasible given our current workforce. That brings me to the policy options that I'd like us to think about here, and I look forward to our conversation. One is, in Medicaid, to very explicitly think about behavioral health within the medical home. It's not enough to talk about the medical home in general. That's important. We've got to start there, but we need to make behavioral health a big part of this conversation. It turns out that the Affordable Care Act in Section 2703, for those of you who are keeping score, talks about a provision called health homes. The idea of a health home is meant to be more holistic. It specifically calls out the importance of medical homes functioning to address mental health, substance use issues, as well as other chronic conditions, including obesity. This is a potential game changer if it is adopted widely and implemented by states. And the way this would be implemented would be that a state would get special permissions to have an enriched matching rate for practices that serve as health homes. And we're talking about a quite enriched matching rate, 90% match from the federal government for every dollar spent in these particular health homes. This is a great opportunity, But as with a lot of opportunities that are dependent on Medicaid and adjustments to Medicaid waivers, it'll be implemented 51 different ways. And that begs the question, well, which one or two or 10 of those 51 different ways is maximally effective? We need to understand this. It needs to be evaluated critically and rigorously. The other thing to understand about health homes is that the way it's written, you can't help come away from reading that paragraph, section 2703, and think, they're not really talking about kids. They're talking about adults with multiple chronic conditions who happen also to have serious mental illness. It's written to be inclusive, but it's perhaps intended to be much more about adults. It doesn't have to be that way based on how it's written, but it's going to take advocacy organizations to help states focus on the child implementation of this. Item number 2 is focusing on the opportunity to understand how the expansion of coverage under the Affordable Care Act, principally through Medicaid expansion, to a lesser extent through exchanges, is impacting children's health and health care. While there are comparatively few provisions in the Affordable Care Act that are focused on expanding children's coverage, because a fair bit of that was accomplished through Medicaid expansions in the 80s and early 90s, and then SCHIP, the SCHIP experience helps us know that actually when adults get coverage who didn't previously have coverage, their children benefit. Their children benefit in terms of sustaining, retaining coverage, and in terms of those children's health outcomes. There's a great need to understand and measure the impact on children of all the expansion and coverage that's happening across the country as a result of the Affordable Care Act. In Michigan, my state, when we expanded Medicaid under the ACA, although don't ask a state legislator, I'm putting on my state hat here for a second. You can't talk to a state legislator in Michigan about expanding Medicaid. They don't know what you're talking about. It's called Healthy Michigan Plan, and it's only barely connected to the Affordable Care Act, just so we all understand. Okay, now I'm taking off my hat. But our Healthy Michigan Plan expected enrollment was 320,000 in the first year. We have enrolled 510,000 adults in Healthy Michigan in the first 9 months. This is meeting a great need in our state, and the question is, what sort of needs is it helping meet for children as well? Item number 3 gets back to the healthcare workforce for behavioral health. How on earth, if I'm suggesting that we focus more on behavioral health, are we going to have enough hands on deck to do this work? There are 3 main ways. One is to help current practitioners understand more and understand better how to appropriately assess, diagnose, and initiate treatment for behavioral health conditions. Another is to emphasize training programs for individuals in the community health worker sector, the social work sector, and then also psychologists and psychiatrists to not only get trained and emphasize their training now, but also to serve in underserved areas. And we know through the Health Resources and Services Administration what areas of our country are currently functioning with mental health services deficits, so-called mental health professional service shortage areas. So those 3 aspects, medical home plus behavioral health, understanding how the ACA and coverage through adults is helping or impacting children's health and health care, and then focusing on the importance of expanding the mental health workforce. Those are 3 areas where I see the greatest opportunity for study and policy emphasis today based on what we know about current limitations of our existing system. Thank you.
Thank you. That was terrific. So, Matt, I think what you've done is begun to lay out both where the deficits are in terms of healthcare for kids and where 2 avenues of solutions lie in terms of the geographic organization of healthcare and the deployment of the healthcare workforce. Okay, our next speaker is Bernard Dreyer. He's at New York University, where he's a professor of pediatrics and leader of the Division of Development Behavioral Pediatrics. Bernard is also director of pediatrics at Bellevue Hospital, where for 3 decades he's led a primary care program that has, among other things, put clinical services in homeless shelters. So you're also going to be talking about the geography of healthcare for poor children. And Bernard also has a more national perspective through his role in organized medicine. He is the president-elect of the American Academy of Pediatrics. And if that weren't enough, he hosts a weekly radio show on Sirius XM called On Call for Kids. What all this means, he says, is that he has spent his working life serving poor children and the families in which they live. And this morning, he's going to talk a little bit about the problems with access to Medicaid and some of the challenges that pediatricians are facing in treating low-income kids in the current environment.
Thank you. It's a pleasure to be here, and thank you for inviting me. And I'm going to try to build on Matt's comments and not repeat anything. And I appreciated and agree with really pretty much every point that he made. I'm going to start, I think, with what it means to be a pediatrician taking care of poor children, and very briefly in my few minutes here, since I've been doing this for 38 years. And thinking about outcomes in health, and we know from research that about 50% of the outcomes of health are really having nothing to do with healthcare whatsoever. Probably more than that, actually, probably 80%. So we have to have, so what that leads me to believe, and from my own experience, is that we have to change what we're doing in healthcare to focus on those social determinants of health as a routine part of healthcare. And I think pediatrics very much has been on the forefront of this for many, many years. Right now, the American Academy of Pediatrics has adopted poverty and child health as their strategic priority and is very much focusing on this in a multi-layered way and also looking at what should be in the pediatrician's practice that addresses this. But today we're sort of focusing on insurance and the role it plays in this. And so I think the story I want to begin with is to harken back to that health home that Matt talked about, which, as he rightly said, is really designed for adult services, and yet the spirit of it seems to come from pediatrics. And one of the issues in adult homes is you have to have two conditions. It could be a mental health condition and a chronic condition, or two chronic conditions. It's very focused on adult chronic care and reducing costs, as a matter of fact. But the chronic condition that we see in pediatrics that actually totally affects outcomes in children through the social determinants of health is child poverty. So wouldn't it be great if one of the conditions that you needed to get that increased reimbursement as part of a health home would be poverty? That would allow us to serve many, many poor children, many of whom have other chronic diseases. 30% of my patients are obese. Many, many have asthma, ADHD. There are many, many chronic conditions that all children have, but in fact that poor children have in higher frequency and often in greater severity. So just to start with, one thought would be, wouldn't it be great if we could change the rules in health homes, either at the state level as an experiment, and include child poverty, or poverty in general, to be, if we're focusing on adults as well, as one of the conditions you need. And the reason this makes sense completely is that we know, and there's a lot of research looking at caring for poor children, specifically in the Medicaid program, and looking at the actual costs you need because of the social determinants that those families have. And it's actually much more expensive to take care of poor kids than it is to take care of middle-class kids, and yet the reimbursement that comes through public funding is actually much less than is available. So the health home model is one possible experiment to allow us to think about how do you fund the programs you need in healthcare to focus on the social determinants of health.
Can I just interrupt 1 second,
Yeah.
extremely impolitely?
Yeah.
Can you just explain a little bit, when you're talking about social determinants, what those are, what's happening and what's not happening in poor homes that make a difference?
Sure. So parents, there are 3 or 4 things out of about 20 things. So one is that money matters. I always quote Larry Aber on that. Income does matter, and there's some good research that shows that actually having more income in and of itself without any other intervention really helps the family. They all have more resources to provide things for their children, especially young children, and they're less stressed out about all of the financial problems that they're having, so they can be better parents. So, so poverty in and of itself, just at an income level, is important. Then I think there is the real focus on parental stress, low education, and their difficulty in providing, because of all the other stresses that they're under, appropriate supportive parenting especially to young children. We know that early brain and child development is where the action is. I just gave a talk somewhere else, but I'll just repeat two things from it. The brain triples in size in the first 2 years. There are 700 synapses that occur every second in the brain of a child in the first couple years of life. That's an opportunity that if you miss that opportunity because parents don't have the skills or the resources they need to help that brain development, that it's really hard to catch up on. So we in pediatrics, in the pediatric office, often focus on helping parents be better parents. There are a number of programs that are out there, either more routinely or in an experimental way, that are looking at improving and supporting, really, parents to provide what kids need. So that's one level of social determinants. The other is domestic abuse, maternal depression, which we need to address, and that's where actually not only co-location with child behavioral health, but access to adult behavioral health is critical as part of this system. So those are some of the social determinants. Let's get to Medicaid. So the problem is, of course, Medicaid, Medicare does not fund, Medicare for adults does not fund as well as private insurance. But Medicaid, in fact, funds about 50 to 60%, is funded at 50 to 60% of the Medicare level, which means that children who are primarily served, poor children, by Medicaid, their physicians are getting 50 to 60% of the money that a physician caring for a senior person is getting. And the Affordable Care Act tried to correct that in some ways. And it was actually trying to correct it for adults because there was going to be, through Medicaid expansion, a huge expansion of adults who were going to be on Medicaid, and there was concern that adult physicians wouldn't take that low rate. But it obviously also affects children who are the primary recipients of Medicaid funding. And so for the years 2013-14, there was so-called Medicaid parity, which increased primary care reimbursement up to the Medicare level for those 2 years. And the concept would be this would improve access to all people taking care of Medicaid patients because more doctors would be willing to care for them, but in addition would give you more funding to be able to provide better services. Unfortunately, it didn't get rolled out until late in 2013. The state governments who were handing it out didn't hand out the money back to all people until mid-2014, and it was supposed to expire at the end of this past year, and it did. So because it was so late in rollout, we don't really have hard data now to say this really worked. This improved access. We need to continue this. And so we're in a catch-22 because we all believe that Medicaid funding, especially for the reasons that I just pointed out, is inadequate. This was one way the government was experimenting with improving that funding, and now it's over without people even having the data to even think about whether this would be an effective way of improving services through Medicaid. So at the policy level, the AP and many organizations are promoting, trying to extend this for another couple of years so that there will be some hard data that we can look at and think about, did it expand Medicaid coverage? Did it improve Medicaid services? And so that's one important policy issue, I think, after the concept of health homes. The last thing I want to talk about before I stop is problems of immigrant children. So immigrant families are in a specific bind in many ways, and I'm going to focus on children and pregnant women because that's my world in some ways. So for children, starting with welfare reform, documented immigrants were not eligible for any federal programs for the first 5 years of their being in the United States. That means if you're pregnant and you're a legal immigrant, you cannot get pregnancy services. If you're a child, you're not eligible for CHIP. I'm a CHIP rather than an S-CHIP person. A CHIP or Medicaid. 2009, CHIPRA, or the CHIP Reauthorization Act, fixed that by offering states the ability to insure those very people right away through federal funding. Unfortunately, only 27 states for children pick that up. That means there are 23 states where that is not happening. So that is, and therefore those children are really not insured, which they could be according to the federal government because those states have chosen not to do so. Likewise, for pregnant women, the similar option is there. There's even an option for pregnant women who are undocumented because the child is considered a citizen. So they're called the child option, where you can actually take care of pregnant women by enrolling them in health insurance because the child would ordinarily qualify for CHIP. So there are about 15 states that have done that, and there's another 15 states that have taken the CHIPRA option just for mothers who are documented. Again, a number of states where pregnant women cannot get care through health insurance and are really uninsured. So I think that's another important policy area that could be focused on. How do we either move the federal government and or state governments to understand that this is a very foolish way of taking care of kids. There are many kids who are still uninsured because of that issue. On a positive note, as was noted before, I think we have made tremendous strides in insuring children. When I first came to Bellevue many years ago, I would say the majority of the kids I saw had no insurance. By the mid-1990s, it was about 40% of the kids I saw were having no insurance. And now in New York State, which is one of the good states from the point of view of taking all those options, I have 0 uninsured children in who I care. That makes a big difference, not because I personally get paid for each child, but because the hospital does, and it allows me to have more resources to take care of them. So nationally, we know that since 1997, when CHIP was started, 14% of kids were uninsured. Now that's down to 7%. For low-income children, those under 200% of the poverty level, that started out as 25%. It's now down to 13%. But for Latino children, many of whom are in this immigrant bind, it started at 34%. It's now down to 17%. So still almost 20% of Latino children are not insured in this country, and many of them are not insured because of the issues of the way we treat immigrants, either documented or undocumented.
Thank you. That's also great. So you've reminded us of the importance of pediatricians thinking hard about what's going on in their patients' homes and in their parents' lives. You've raised the question of whether poverty itself can be a criterion for the heightened reimbursement on medical homes. You've talked about the sort of almost missed opportunity to find out what happens when you raise Medicaid reimbursement under the Affordable Care Act. And you've raised some important questions about kids who are immigrants, so thank you. Okay, Anne. Anne Marcus is based here in DC, where she is an associate professor of health policy at the George Washington University. She is training in both health policy and in the law, and in the United States and in Switzerland. So she brings a pretty eclectic set of perspectives to her work.
And I'm not a pediatrician, so I didn't want to make that correction.
Anne's looked broadly at issues of children's access to care, particularly within the context of the management of chronic diseases. In particular, she's the principal investigator of a research project involving children with asthma who get care in federally funded community health centers. And after listening to these two broader sets of perspective, Anne's going to talk about sort of a case study of asthma, which happens to be the most common chronic disease among children. Anne.
Thank you very much, and I'm very pleased to be here. Hello, everyone. And what I thought I would do first is make some comments about the relationship between poverty and asthma, because there are some things we understand about that relationship and other things we really don't quite understand yet. I just want to emphasize some of the current thinking around that. Then I'll move to some actual statistics and data and facts about the relationship between children who have asthma and who are poor, and the various aspects of the care they can obtain or not obtain in some cases, and what some of the other issues that arise along the lines of the social determinants of health that were just alluded to earlier that might prevent their improvements in their health and their well-being. And then I want to conclude with some ideas about some current interventions that might be effective in addressing some aspects, some of the gaps that I will be highlighting, and where are some of the barriers still in terms of diffusion of some of these interventions, and the fact that also they're very much focused still on clinical care with some, wraparound services, and do not stretch much beyond that at this stage. So this is how I structured my talk. The first thing I want to talk about is the fact that childhood asthma is really kind of a strange paradox. Scholars have talked about it both in terms of a disease of affluence and a disease of poverty, which is somewhat of a paradoxical thing. So I wanted to go through both of these ideas to highlight that in some ways, even though they seem contradictory, they're both highlighting two aspects of the issue here. So why is that? It's first a disease of poverty because the data are quite clear. There's a much higher prevalence of asthma among children who are poor in the United States. Other countries, there's less certainty about that particular relationship. But in the United States, since we've been tracking those statistics, that has been demonstrated over and over again. And that hasn't really budged since we've been tracking that statistic. And so that is something that we can be fairly certain about. We're not quite sure completely what all of the mechanisms are that explains this relationship. We have some ideas, but not a complete understanding of that. And it is a disease of affluence as well because, as you know, American society and other societies have made great advances socioeconomically, politically, in medical technology, in the way we control and change our environment. And we have built the capacity to protect ourselves from all kinds of diseases, particularly infectious diseases, which were the most prevalent causes of morbidity and mortality, among children, especially young children under age 5. And so we've been able to protect ourselves against that, but not so much lately against the emergence of other diseases, not that they were necessarily not there already, but because children are living longer, and we've emphasized early diagnosis and prevention of some of these diseases, we've started to pick up more on certain chronic conditions and other conditions that require long-term services that might stretch beyond typical clinical care, and that are costly. And those kinds of conditions require new solutions. And what those might be are still things we're trying to figure out, we're testing out, we're trying to roll out, and we're trying to think about new ones. What might be some of these more prevalent chronic conditions? As Amy just stated, obviously childhood asthma is one of those. It's the most prevalent chronic condition, common chronic condition among children in the United States, as are allergies. And I wanted to raise this because of the relationship that has been shown in the literature between the emergence of allergies and asthma. And in fact, the majority of children who have asthma also have sensitizations to allergens in their environment, whether it's outdoors, in their home, at school, that can act as triggers to their asthma and create asthma attacks. And if you don't know what to do with that, you may end up in the hospital unnecessarily. And so that relationship is something important to highlight, so you understand also what I'm going to talk about next. which are, I want to give you a sort of a portrait of what we know about poverty and asthma and what we may not yet know. And so the very first thing is, as I stated, prevalence is very much higher among children who are poor than children who are not poor. And that's particularly true also compared to poor adults. The statistics show that 13.5% of poor children who have asthma are poor, compared to adults, about 10.6%. And also compared to children who are well off, 8.3%. So there's a clear disparity there. It is also important to look at the severity of the diseases. Asthma can be a very mild condition, or it can be extremely severe. And there is certainly some research that suggests that that income contributes to how severe your asthma might be. And for example, it might manifest itself by the fact that you might have a severe asthma attack and have a more frequent need to go to the hospital and end up being hospitalized. It's one criterion that's being used to describe severity. There are many others that my colleagues can probably talk about much better than I can. We talked about access to care in the medical home, and there are data that show that the majority, in fact more than 1 in 2, poor children who have special needs, which include children who have asthma, do not have a medical home. So they do not have a regular doctor, they do not have a regular nurse, they don't have a usual place, a clinic to go to for sick care or well care, whatever it might be, and they lack that good care coordination that was mentioned earlier. And that's very important when you have multiple needs, and needs, again, that stretch beyond clinical care, where you might need help with your housing and other situations that a good care coordinator might be able to provide. And so this is compared to 30% of children who are not poor. So there's quite a bit of a difference as well here. Continuing on the theme of access to care, another important aspect which was highlighted earlier is the need to get referrals to specialist care, whether it's behavioral health. A lot of children with asthma also have a lot of behavioral issues that need to be addressed. There are other kinds of specialty services you might need, pulmonologist, access to an allergist, a number of other specialists that might be necessary for your care and to maintain good health. And again, poor children who have special needs, which again includes asthma, say it's a much bigger problem for them to get a referral to that kind of care. About 22% said it was a very big problem, compared to 12% of children who are well off. Medication management, very important in controlling asthma. And as you know, pharmaceuticals can be quite costly, especially if the brand drug is the preferred course of treatment for a child. And of course, poor children with asthma are much less likely to be able to afford those prescriptions, especially if they're not uninsured. And the research also shows that they're much less likely to be prescribed an anti-inflammatory drug, which is the current recommended clinical care for managing severe to moderate asthma. The research also shows that typically poor children who have asthma have lower adherence to the treatment that's being recommended for their pharmacotherapy. Another final biggie, of course, is the cost of care. As I mentioned, if you're poor, it's very hard to afford your care, any type of care. But luckily, many poor children actually have insurance. They are covered under Medicaid. In fact, Medicaid is the largest source of coverage for poor children. 77% of children who are poor are covered by Medicaid, compared to roughly 7% of children who are poor who have employer-sponsored coverage. And the uninsurance rate has decreased dramatically over the past 2 decades due to some of the expansions that were mentioned earlier in the 80s, and then CHIP being enacted in the 1990s. But as we all know, this is not a guarantee. The other thing I want to highlight about the relationship between having Medicaid coverage and asthma is that Medicaid actually covers a higher proportion of children who have asthma. So it is a program that does need to address the specific needs of children who have asthma. And although Medicaid has a comprehensive set of benefits and limits or completely prohibits cost sharing out of payment pockets for children, it also does not completely fully cover the continuum of services that a child with asthma truly needs to properly manage their care. And there's a lot of variation by state as well. So one state might be more generous than another, but typically there's certain items that might be completely excluded, or certain settings in which some of the care might be provided, like the home, which might change with the new rule that's been issued recently if states decide to pick up that option, where that care might be provided and reimbursed for. So there's still barriers despite the fact that Medicaid is very comprehensive otherwise in terms of preventive and developmental services. Now I want to move to other areas that where we know what some of the barriers are for children who have asthma. And one big area is schools. Obviously, children spend a lot of time in schools, and research does show that poor children who have asthma tend to go to schools that have fewer resources, that have problems with the infrastructure, low maintenance issues, leaks, tendency to have mold and other things that, again, present triggers to potentially having asthma attacks in that setting. Education level. Poor children who have asthma tend to have lower levels of education, and more importantly, I think in this case, a less grounded understanding of what asthma is and how to manage it. And so that's a very important, some of the interventions I'm just going to allude to in a few minutes. Housing. Poor children who have asthma tend to live in public housing or in homes where their families have no control over the carpeting, the walls, the bathroom, plumbing, and may not even able to afford some of those changes that need to happen to again reduce the exposure to some of those things that might happen in the home, like mold and cockroaches, that are more common in housing that's not properly maintained. And finally, but not least, the environment and air quality. Research and data also show that poor children with asthma tend to live closer to highways, closer to industrial parks, where air pollution can be worse than in other areas. And again, that is a trigger that has been demonstrated to be related to asthma attacks. So it's complex. There are many factors, as you can see, and this is just brushing over the data. There are actually quite more on various aspects of this. So how might we tackle this problem? Because there are multiple factors, they're interrelated, they're different sectors. It's not just the healthcare sector, it's not just the public health sector. There's housing, there's other sectors involved in potentially tackling this issue if we really want to make a dent and address asthma among children who are poor. And as you said earlier, it doesn't involve necessarily the healthcare system at all, or even Medicaid or CHIP for that matter. Although I would agree that there should be some coordination and discussion about how some of these pieces might be put into place. So there are, thankfully, some solutions out there, and there are some interventions that have been tested in previous clinical trials funded by NIH, mostly, that have shown some efficacy of those. They tend to, as I said, focus mostly on making sure that first and foremost children with asthma get access to adequate care, and make sure that they're assessed adequately for their severity and control, and then prescribe the proper medication to make sure that they can control and maintain their health. It's by providing access to primary care services. Mentioned the medical home issue where lack of access, so trying to encourage a link to a provider a primary care provider, because asthma can be very well managed in primary care, making sure that that link happens. And also emphasizing education and counseling, so really understanding what the disease is, how to recognize symptoms, what to do about it when symptoms arise, how to use the medication, the inhaler, the nebulizer, the spacer. It's complicated, and it's a daily thing that needs to occur. So these interventions tend to be multi-components that address these three main aspects of care, but you'll notice that they do not address other things necessarily. In terms of changing the housing, you might teach a family how to clean some areas of the home, but it's not, addressing beyond that, and that's problematic because it's somewhat superficial in some ways to just do that and not address infrastructure issues with housing. The previous panel alluded to pilots and research and how effective interventions sometimes do not get rolled out and picked up system-wide. And this is certainly one type of intervention where the evidence is building that it's working in real practices, it's working in communities, their local governments adopting community-wide approaches along those lines, yet it's not a widespread standard of care in the healthcare system. And why is that? We're still trying to understand, and the researchers were just focusing on that and understanding that. And it's also becoming increasingly evident as it is rolling out to some extent that, that again, while it will help tremendously to implement these types of interventions, they're limited by the fact that they're not focusing on some of these other determinants of health that might even make a greater dent in reducing the gap between children who are poor and have asthma and other children who are better off. So I will end here.
Thank you. So you've done a great job of looking at the healthcare, and health insurance of poor children through the lens of asthma. And I was particularly interested in your pointing out the distinction between prevalence and severity. It's a big deal issue. And also pointing out that there are lots of environmental factors in kids' homes that have a bearing on that severity, I think was the implication that you were making.
Correct.
And that there have been some hopeful attempts made, but it's not all cured. Okay. So how much time do we have left? Yeah, that's right. That's what. Okay. Well, let me ask one super distilled question of each of you, and then can we have like 2 questions? Is that okay? Okay. So from you all look pretty happy. So from each of your vantage points, let me ask this from same question, 2 different sides. What's the biggest thing the government could do at this point to make a difference, or what's the biggest thing that's missing? And if in asking that, one of you could slide in something about the fact that CHIP funding is going to run out in September, if government doesn't do something about it, that would be a good thing to add in. So Matt?
Why don't you start right there, Bernard?
Okay, well, so absolutely, I'm happy to take that on. So as both of us said, CHIP funding has made a huge difference in the care in the insurability of children and therefore their access to care. In addition, and so the concern about CHIP going away is that it's not easily replaced by the Affordable Care Act, as the Affordable Care Act is now. The Affordable Care Act has what we in pediatrics refer to as the bank problems. There are benefit issues. So the benefit packages of the ACA, which get played out at the state level, are not really designed for kids. And there are things that are left out. There are many habilitative services for chronically ill kids that are not included. And the entire package of CHIP and Medicaid has very much been geared towards what the needs of children are in health care. That is not the case for the ACA. Could that be rectified? Yes, but it is not rectified at the moment. So that's the B.
And maybe not in a Republican Congress.
Yeah, and that's the B. The A is the actuarial value. So we know, all of us have been on the websites, that is the Bronze Plan, et cetera. And the Bronze Plan means that you pay 40% out-of-pocket costs. Most poor or near poor people cannot afford to pay 40% out-of-pocket costs. And CHIP has an actuarial value of 98%. So parents pay almost nothing out of pocket. The N is narrow networks, so that again, the Affordable Care Act is has one of its goals is to save money, and therefore many of the organizations are narrowing their networks to primarily focused on adults. to try to save money and not and have a group of providers that they can work with. That is not what kids need. Kids need access to children's hospitals, access to pediatric subspecialists. Many of the networks that exist now don't have those resources in it. And finally, there's something which is somewhat, I think, less important, but still important, so-called kid glitch or family glitch, in which the Affordable Care Act, in order to get subsidies, for the poor people to get subsidies, it's only focused on the one adult in the family and does not take into the cost of the insurance for the entire family. So the insurance cost for the mother or father may be okay, but if you start adding all the other family members, they won't be able to afford it. And so kids could actually, they may not be able to afford getting insurance for their kids, and it's estimated that up to 2 million children could lose insurance if CHIP were removed and they were put on to just going through the exchanges. Now, I want to reiterate what Matt said, which is we're really positive about the Affordable Care Act. It has, insured many, many people, and we all believe that children do better when their parents are insured. So just from the narrow perspective of children, it's a good thing. There's also been some hope of the Woodwork Effect, which we haven't seen yet. And so what is the Woodwork Effect? There are many children who actually could be on Medicaid and could be on CHIP, but are not enrolled by their parents. And there was a sense that as parents went on to the exchanges to enroll themselves, they would be given the options to enroll their kids at this point in Medicaid or CHIP, and would do so.
And the fact that the law requires most people to have insurance.
Right. So, however, I can tell you that so far, the uninsured rate in children has not dropped further. So if there's a Woodwork Effect, it's not a major effect as of yet. Maybe we'll see it further down the road.
If I could just add to those wonderful points. Currently, Medicaid in just about every state has a provision that allows women, when they become pregnant, even if their incomes are approaching 200% of poverty, to get coverage during that pregnancy. And then 6 weeks after their delivery, their eligibility is gone. That effectively says to women in our communities, your health matters to us, but only if you're pregnant. That's A, bad message. And B, it's really wrong-headed when it comes to children and families. Through the Affordable Care Act, what's happening now, and needs to be measured, you see a theme in what I'm emphasizing here, needs to be measured, is the impact of women of childbearing age having coverage in the preconception and interpregnancy period. Because by having women of reproductive age know if they have high blood pressure, know if they have diabetes, know if they have depression, get help if they have substance use disorders, that could be vital to healthier pregnancies, pregnancies that have a better chance of going all the way to full term, because we know one of the key risks for children is being born prematurely and or low birth weight. And that message could be very good policy and, dare I say, outstanding politics. It's about women's health. And women vote more than guys do. And this is an issue that it provides a tremendous opportunity, I believe bipartisan opportunity, to make a very positive change in Medicaid. This is an opportunity that builds on actually the greatest expansion of Medicaid eligibility before SCHIP, which was Medicaid eligibility expansions during the Reagan administration. Yes, I said the Reagan administration. So there are opportunities here which are not out of bounds. They aren't crazy, big, dreamy ideas. They are evidence-based ideas that can impact not just the person who gets the coverage, but the next generation as well.
I want to add about CHIP. So CHIP is also a bipartisan opportunity. It was started in a bipartisan way. And actually, I think there is some good chance that there will be a bipartisan support for refunding CHIP for the X years in the future, until such time that the Affordable Care Act insurance plan actually can meet the needs of kids. And so I'm very optimistic that it will be refunded. We're actually hopeful that rather than just a short-term 2-year refunding, we might get 4 years, which would give us more of a cushion not to worry about things until other methods do or do not get worked out.
I'm going to put a slightly different hat on, which is more of my comparative healthcare systems hat. And even though we've reduced the uninsurance rate tremendously over the past two decades here, I still think that 7% of uninsured children is just an anomaly. And that we still need to continue to make sure that we're expanding coverage and not losing ground, as some of you have alluded to here with some of the concerns with ACA and some of the other provisions around CHIP. But also with the current health insurance system that we have, both Medicaid and CHIP, strengthening some of the services that really should be provided to children, regardless of where they live, and somehow convince Medicaid, state Medicaid agencies to think about chronic conditions in a different way, and sort of transform how they've typically been paying and delivering services, because the needs are different, and they might see a bigger return for their investment as well.
And I agree, when you unpack the 7%, as we were saying before, it's not really 7%. It's really almost 15% of low-income children and almost 20% of Latino children. If you look at the non-low income, the higher income, it's much lower. So really what we're talking about is a higher percentage of poor and near poor children. The 7% kind of hides that. It's still a great victory, but you're absolutely correct in that that's not good enough.
Are there a few burning questions among those of you who've been listening patiently all morning?
Very.
Not so burning, but if we were with one of those adult health homes or with the ACA, we would look at what conditions are bringing adults to the hospitals. We would intervene there and try to reap some of the funding. And when we look at that for children, as I did working with the Medicaid medical directors, and it's in a paper in Health Affairs, and as I just now did with HCUP data, and it's in my top left-hand drawer at the moment. But when you look at what brings kids to hospitals, particularly adolescent kids, far and away, is to have a baby. And this
Correct.
is kids 10 to 17. That's the top diagnosis.
Most common, that's correct.
And then followed by mental behavioral, which is the top for private. Pregnancy is not the top for privately insured kids. Followed by respiratory, and that's driven by asthma. The mental behavioral is driven by mood disorders, which is driven by depression. And the pregnancy is driven by, well, being pregnant. It's not considered, it is the third rail, it's not considered preventable, but of course even the Pope made an announcement that as much as acknowledged, and that would be where we would be intervening. And this kind of builds on your comments, Matt. I mean, say something about that. The highest cost, and it is the highest cost in the aggregate. That would be where we would be intervening if we were taking care of adults. So please comment.
Gary, you make marvelous points. I love that they're as evidence-based as they are, and that's been one of the greatest contributions you've made through your career to children's health, and I want to say thank you for that. Yes, it is alarming, surprising, stunning to some people that the most common reason adolescents in the U.S. go to the hospital is to have a baby. That's not exactly a headline, and yet it is a big concern. How would we intervene? You're right, in a growing number of states, this is a third rail conversation. Yet, there are ways to have a productive, constructive conversation about approaches that can be implemented in schools, in communities, to try to encourage kids to, quote unquote, do the right thing, whatever that may be, culturally acceptable for them and for their families and for their communities, in terms of trying to not get pregnant. As many of you in this audience undoubtedly know, the teen pregnancy rate in the US remains among the highest in the developed world. We actually have made remarkable improvements since the 1990s. We tend,
Absolutely. No,
we've cut the rates about in half. And it's been a lowering tide brings down all boats in terms of the rates coming down for all groups. Yet we still have a 2-to-1 disparity for teen pregnancy for African American youth versus non-Hispanic white youth. So still a lot of progress to be made. I would argue that the declining rates in recent memory suggest that actually there are some productive ways to have this conversation and to help teens to focus on other areas of their activities, shall we say, rather than activities that would lead to pregnancy. It is a very tough conversation to have. I've wanted to have it, again with my state hat on, many more times than I was encouraged to do so. But there are some wonderful, very constructive community-based organizations that are ready to roll out really positive programs that can have an impact at the local level. And hopefully someday bring the hospitalization rate for pregnancy among teens lower down on the list. The number 2 category connects back, I would add, right to my main focus, which is behavioral health, and the fact that certainly behavioral health concerns are paramount for parents of young children. For parents of teens, even more so. And they're especially challenging when we have concerns about adolescents turning into their own selves as individuals, but also parents trying to play a role in terms of providing that help and support at a critical time of developmental vulnerability. And while the awareness around behavioral health needs for teens has really improved, I would say, and there's a greater willingness to have this conversation about the emotional mental health distress of teens today, our investment in the mental health system has not kept pace with the social and cultural awareness of this problem in our communities.
If I can make 2 comments, Jerry, on your excellent comments. One is about teenage pregnancy. We actually know what to do to help teens not get pregnant when they don't want to, and that's long-acting contraception, which should be part of any adolescent medical home. And but we're not there yet. So I think that's just a comment on teen pregnancy. I think somebody mentioned a recent article about Medicaid giving cost savings for adults. And one of the theories in that article is that because women did a lot better than the girls did a lot better than the boys in the long run, as far as making more income, was that access to adolescent health prevented a lot of teen pregnancy. So again, that issue of lifelong trajectories being affected by our inattention to things in childhood. And I want to just make one comment about your comment about comparing us to adult health homes, which I understand why you said that. But I do think we need to take a leap and say that pediatric health homes are different than adult health homes. We are not only interested in saving costs or decreasing hospitalizations. Not that we don't want to do that. But what we want to do is change the lives of kids. And that's why I think looking at poverty and the social determinants as what we need to be doing in those health homes is important for us to sort of change the discussion about what a health home should be doing.
Yes.
I may have missed this, but you talked about the adequacy of each health home. Are there enough health homes? Are there enough doctors willing to accept Medicaid? And can poor parents get their kids to the health home, and do they? I don't think we've discussed much about that. And how do we intervene?
Well, we do know, these are some simple answers to your complex questions. What we do know about access to Medicaid for poor parents to Medicaid is that the amount doctors get paid is critical to their willingness to take care of Medicaid patients. So that's why the Medicaid parity that is no longer with us as of December 31st is perhaps a very important factor, policy factor, to make that much more accessible. I would just say that. And there is some evidence from doctor surveys during 2013-14 that is exactly the case. There was an Ohio May 2014 study in which doctors who were already taking Medicaid patients said they took many more because of the increased rate Doctors who had never taken Medicaid patients said they were now taking Medicaid patients. And doctors said that if it were permanent, they would actually think about how to design and change their practice to include Medicaid patients in all of their needs on an ongoing basis. So I think that's an answer to one of those questions. I think the other question is, do parents access those resources? I think they generally do in early childhood. I think it falls off after the fact. And that gets to this health home for poor kids. You need outreach resources. You need people to go out into the community in order to really serve poor children in a health home. And a medical home. So we should just not confuse health home with medical home. Medical home is a standard good idea about comprehensive care and coordination. A health home is a higher reimbursement for more complex patients, but similar concepts as far as what you're supposed to do.
Jeff, it's really too early for us to say whether the health home idea, as Bernard just reminded us what it means, which is this higher reimbursement for complex care, whether that's going to be a successful model. It's still too early in terms of state adoption of this and practices stepping forward and saying they're ready to do it. I would add that there are other examples of innovations, one in particular from the Center for Medicare and Medicaid Services called state innovation models, which are more explicitly about involving the communities in taking on responsibility for working with public health and healthcare providers and say, you know what, we're going to really do a much more comprehensive job around housing and environmental risk and preventive care, and also, yes, trying to use the emergency department more effectively, primary care